It's a real honor to be here with you guys. I don't know each of your stories, although I'd like to, but I'm going to try to give a general overview. But again, if you have questions, please stop and interrupt. We do tend to get a little, I was kind of chuckling to myself as Dr. Kanan's talking and saying all of these agents, and they do start to sound confusing, although I'm sure a lot of you, get used to the lingo as you go through your treatment. Certainly becomes a part of your, lives. I'll echo what Dr. Kanan says. I think, so much has changed with cancer treatment with the multidisciplinary approach that we have so many options. And I think I've had the benefits of working in larger centers where most of my patients know about those options, but I think it's great to be able to bring those to you guys if you haven't, heard of some of these things or thought of some of these things, to ask and to get that kind of care. I can't help but start off with a little anatomy. That's what surgeons do. So your liver, I'm often showing people this in my office, saying where the liver is. It's a largest solid organ in the body. It has a lot of functions, as you'll come to find out, that are important. It also has a lot of reserve, which is one of the amazing things about it, a lot of regenerative capacity, which allows for us to remove large portions of the liver without needing a liver transplant. You still have enough good functioning liver that it can make up for taking out the parts that are not working because of the cancer. With that regenerative capacity, the liver works to filter toxins and drugs in your body. It also makes a lot of your proteins, helps digest foods with the bile that it secretes. It helps you clot your blood. And so all of these things come into play with your cancer treatments, because if your liver isn't functioning well, some of these things can become out of whack, and that's important for what kind of drugs you're able to get, or when you can get surgery as an option. A chance to cut is a chance to cure. We say that. I feel like I have a lucky specialty, especially with these liver tumors, that we have come such a far way with advancements that we're able to cut out a lot of these tumors that we were not before. And if we can get out all of your disease, we call that a cure, and that's our goal from a surgery standpoint. So that's how I look at the images and how I look at you as a patient, to say, when I cut you, am I helping you? And if I'm leaving cancer behind, I don't consider that helping in most situations. Now, there are, differences in every patient, but that's kind of a general principle. So we already kind of went through these. I've heard a couple of these mentioned already today: cholangiocarcinoma and metastatic colorectal cancer from a few folks that are here. Lots of different kinds of cancers, and they're treated differently from a surgical perspective, in that some of these we know the biology of the tumors, and we found that removing them with surgery is a really good chance. And then some of them we found that removing them with surgery, they spread other places, and we would have been better off going with chemo first to treat you systemically. And so we kind of look at all of those things when we're talking to you. So from my standpoint, what are the options? I'll talk with you about the surgical resection of the tumors, cutting them out, but also a little bit that was mentioned earlier about radiofrequency ablation, or RFA, ablating those tumors, burning them. And we've actually found sometimes surgeons do that, sometimes interventional radiologists can do that, and you'll hear that talk in a little while. It's the same procedure, but the benefit of doing it at the time of surgery, if you have metastatic colorectal cancer and you've got multiple tumors, maybe one is near an important structure, this allows us to maybe be able to cut out some of the tumors and burn out some of them, which is still a cure in our minds, because those tumors have found to have very similar results to cutting them out, which has been a big improvement. Another advancement in the surgical realm, which has been really nice for cancer patients, is minimally invasive approach, laparoscopic or robotic, and I'll talk a little bit more about those benefits in a second. So the first thing I'm asking is, can I cut this cancer out? Or if I can't cut it out, can I cut some out and burn out some of the other parts? It used to be, the old teaching was that you couldn't have any sites of disease outside of the liver. So let's say you had colon cancer metastatic to the liver, but also to your lung, then we would say, oh, we're not going to cut that out because it's somewhere else. It's not true anymore for a lot of tumors, especially colorectal cancer. You can get the lung metastases cut out as well. So that's changed. That is not true. That is not a hard and fast anymore. And it used to be that you needed to get a centimeter margin. So that's just the mark around the tumor of good liver that we've taken that says that there's no tumor spreading microscopically when they look at it under the microscope. And we found that actually doesn't have to be the case anymore either. We just want a negative margin. It can be 1 millimeter, it can be 0.5 millimeter, but if it's a negative margin, that means that those edges are clear of tumor, you've got good liver in there, and we can give other treatments: radiation, ablation, chemotherapy. And so really the new definition of is your tumor resectable? Can we cut it out and still leave you enough liver to have function? That's really the biggest thing. And for most people, you only need 20% of your liver if you have a normal functioning liver. And so that means no cirrhosis or no kind of other damage, which is a little bit hard to say, but we can tell on imaging a lot from that standpoint. There's a couple other adjuvant treatments that I'll mention. Dr. Kanan already talked about getting chemotherapy prior to the surgical resection. That can shrink the tumors, that can tell us your tumor biology and how things are going, and allow us, maybe we thought before you were going to lose too much of your liver, but now after we've been able to shrink the tumors, we can cut those out and still leave you with enough functioning liver. So that's been a huge play between the teamwork for our two specialties. Interventional radiology helps us again in this field. They're able to do something called portal vein embolization. So this was just a case presentation, and it actually does not project extremely well on here, but here's the tumor here in the liver, you'll see. And this is just with after chemotherapy. And it's a really significant change in that tumor. And we used to think that we still needed to cut out this amount of liver because there was tumor there before. We have found that that is not the case. So we are able to save good liver and just cut out the smaller amount. So it can really help when you have multiple tumors and if your liver isn't functioning quite at a normal weight. This is very sciencey, so forgive me a little bit, but I think the picture is pretty good. So portal vein embolization, the whole point is that you're cutting off, the portal vein gives some of the blood supply to the liver. You're cutting off blood supply to that side of the liver that has the tumor so that it's kind of, in theory, dying off. The other side of the liver, that's the healthy side, will then get more of the blood flow, allow it to grow. That's the beauty of the liver. It regenerates and it can do this. And so that allows you to have more good liver so that we can cut out big tumors on the other side. This is just an example, surgical resection, this metastatic colorectal cancer. There's CT scan images up here. They're showing your liver, the big white on the side on the left. These little dark spots are all the tumors. And so when we think about surgical planning, it's really kind of a mapping, and it's what can we burn, what can we cut out. And so in the operating room, you use ultrasound. You can't see these lesions on the surface. You can see this one. The white is the tumor. The pink red is the normal liver. And so map those out, and you can even just do wedge resections. Just take out this small part of tumor. You don't have to take out half the liver. So you can do that, and you can save parenchyma. That's what we always talk about, parenchymal sparing. So we want to just cut out tumor and leave as much good liver as we can. And then the radiofrequency ablation that I mentioned, we kind of blow through it, but just so you guys see sort of what it looks like. It's probes, and they go in flat, like the shape of this probe, goes into the tumor, and then you deploy it. So you're in the center of the tumor, you deploy it, and all these tongs put out the radiation. And that just burns that area. It's very directed, and it can be done in surgery or it can be done in interventional radiology just through the skin. Colorectal cancer is one that I seem to focus on because we see it a lot. It's really common. Metastatic colorectal cancer, unfortunately, is about 50% of patients that present with colorectal cancer will have liver metastases. And also, when I was training, sort of the adage that we learned about is not to think of metastatic colorectal cancer as, a terminal illness. It's really a chronic disease because we really can continually treat it. Even after we've cut out tumors for colorectal cancer in the liver, 5 years later, tumors come back, we can cut it out again. And I've done that as many as 4 times on a patient. Now, obviously, everyone's situation is different, but it's just changed tremendously from what we thought it was before. The minimally invasive side of things, it's fancy, you see it on billboards, but it really is important to patients from the standpoint of getting you to your chemotherapy quicker, getting you back to your life quicker, the healing standpoint. We can do many surgeries robotically that definitely didn't used to be done. Liver resections has been relatively new, and also some other things that might be relevant to you depending on your type of cancer are pancreatic surgeries and splenectomies, and colon resections as well. And all of these things just allow us to, get you less pain, less scarring, out of the hospital sooner, and really most importantly to chemotherapy sooner, because that's our goal. And if you have a surgery and you have wound healing issues, your nutrition isn't great, you're weak, you can't start chemotherapy. And we all know that, cancer can spread to all places by the blood, and so we really want to get you that chemotherapy, even if we can cut it out with surgery. So that's the main goal for us. In summary, what I'll say is it's very complex, even for folks in the medical field. Everyone has different opinions on which route you go first, what treatments you do. That's why tumor boards are important, and that's why having a team is important to get everyone's opinion. And it's also why putting the word out there and getting a second opinion, you should always do that if you want to do that, because everyone's going to have different thoughts on things, and it never hurts to hear what those thoughts are. And ultimately, it's going to be about you, about your life, and what treatments you want to do. But it certainly helps to have all the options, especially when these things are available. And I will echo that you should have a surgeon look at your scans, because there are many times when a radiologist might read something and say, I get this all the time, it just says multiple lesions in the liver. And it doesn't say how many, it doesn't say where, it doesn't say what they're part of, and they'll just say, oh, it sounds unresectable. It sounds like they couldn't cut it out. We can cut out a lot, I'll just say that. And so I think you really does benefit you guys to show your scans. The radiologists are looking at them and saying what they see, but they're not always looking at them to try to cut them out. They're just looking at them and reporting, oh, we see a lot of lesions. I'm looking at them to say, is it close to this vein? Will there be enough liver left? What can we do from that standpoint? Can I burn some out? So definitely show your scans, the pictures themselves, not just the reports.